And then we'll move into a combination of presentations and discussion. Today, we're joined by Bernard Jones, the Chief of Staff and Vice President for Public Policy at Brigham and Women's Hospital, along with Thomas Walsh, the Vice President for Analytics, Planning, Strategy, and Implementation for the Indian Health Service. And we also have Cindy Peterson, the Vice President for Regional Ambulatory Operations and Business Development for Brigham and Women's Hospital as well. Finally, a couple of housekeeping items. Please share your questions throughout the presentation using the Q&A feature of Zoom. This is a recorded session, and your participation serves as consent to be recorded. The recordings will be made available following the presentation. For the presenter slides, please refer to the Echo link that was sent out by email prior to the presentation. And there is CME credit available. A link to the post-session evaluation will be provided in the chat feature of Zoom. Please click on that link, complete the evaluation to receive CME credit. And with that, I'd like to turn the call over to Dr. John Irlew from Gallup Indian Medical Center to provide a clinical update. Thanks, Dr. Irlew.
Hi, thank you. John Irlew, infectious disease doctor here from Gallup Indian Medical Center. I'm going to give the weekly COVID-19 update. Last week I did not give the update since we had a pediatric presentation, but I'd like to get started here. So if I could have the second slide, please. Great, thank you. So I have nothing to disclose. Next slide, please. So a lot of really exciting things happened in the last 2 weeks. There was a very interesting study that was published online by the Scripps Institute on June 12th, showing that there's been a change in the COVID virus, the SARS-CoV-2 virus, since the first appearance of the virus in Wuhan, China back in December. So there's a brand new mutation called the D614G mutation that appears to increase the infectivity of the virus, according to this group from Scripps. So what they found is that this is a mutation of the spike protein that changes the COVID virus so that it has up to 4 or 5 times as many spikes as it used to have at the beginning of the outbreak. And the spike, the mutation, which substitutes in a glycine amino acid into the spike, makes the spikes more flexible, and therefore they're better able to bind to the human ACE2 receptor, and was not seen early on in the COVID pandemic, and especially in the virus that showed up in Wuhan and then made it to the United States on the West Coast. But it made its appearance and started to become prominent in Europe, in Italy, in France, etc., and then into New York. And we all know that it's the New York virus that spread across the United States and it affected Indian Health Service sites. So a little bit scary. The virus has changed. It's possibly become more infective, according to this group from Scripps. And you can read their press release by clicking on that link that's at the bottom of the slide. Next slide, please. So some interesting data from the Diamond Princess cruise. This is an article that was published in the New England Journal in June, and it's called Natural History of Asymptomatic SARS-CoV-2 Infection. So they looked at 712 people out of the total of 3,711 persons who were on the Diamond Princess cruise, and these 712 were ones who were infected with SARS-CoV-2. And of those 712, 410 of them were asymptomatic at the time they were evaluated. And a subset of these were transferred from the ship to a hospital in Japan, along with 32 of their negative cabin mates. So there were 96 of these were basically asymptomatic people. Of this cluster of people, 90 remained asymptomatic throughout their hospitalization at the Japanese hospital, but 11 developed symptoms within 4 days, and their median time to develop symptoms after the COVID diagnosis was 4 days. So you call these people pre-symptomatic. And what they found was kind of interesting. For every extra year of life, the relative risk of becoming pre-symptomatic, meaning going from asymptomatic to having symptoms, increased with an operative risk of 1.08 per year. So as you get older, you have a higher likelihood of going from asymptomatic to actually developing symptoms. So that was kind of an interesting natural history study. Next slide, please. How about the neurologic manifestations? This was a pathology, neuropathological study published by Solomon et al. It's an autopsy series of 18 consecutive patients who died of COVID. And this was at Brigham and Women's Hospital. And I'll just put in a plug here, arguably the greatest hospital in the world outside of the Indian Health Service. And in this study, the median age was 62. All had a confusional state or decreased arousal from sedation on a ventilator. They did CTs on several of the patients. 3 of them were normal. 1 had evidence for a resected brain tumor. They did not do spinal taps, MRIs, or other fancy neurologic evaluation before death. And when they actually did the postmortem evaluations, all of the patients had evidence for hypoxic brain injury in the cerebrum and the cerebellum with neuron loss at special focal sites. But they did not see evidence for thrombi or vasculitis. So they did not see COVID-induced blood clots or blood vessel inflammation. Only 1 had evidence for meningeal inflammation, so basically like a meningitis picture on that one autopsy. So the take-home message from this is, for patients who develop severe lung disease with ARDS who die, the only pathologic findings in these patients in this study were hypoxic changes without evidence for encephalitis or specific brain changes from the virus. So we've talked at previous sessions the fact that you can see stroke and cerebrovascular disease with clots caused by COVID. But in this autopsy series of people who just died of pulmonary disease, they did see hypoxic brain injury, as you would expect, but they did not see other viral changes in the brain. So kind of I think a very interesting and helpful study, even though it's unfortunately from an autopsy series. Next slide, please. How about an update on gastrointestinal manifestations? We revisit this concept. We talked about it over a month ago. This is a huge look-back study of presence of gastrointestinal symptoms, pardon the typo there, in patients who had COVID-19. This is published by Parasa et al. And they looked at actually 23 published studies and 6 pre-printed studies for a total of 1,484 records. And they basically settled it down on 4,805 patients that they were studying with GI symptoms, who had a mean age of 52. And just like all the other studies on the gastrointestinal manifestations, just a small percentage, about 7% had diarrhea, about 5% had nausea, vomiting, and identical to the study we discussed earlier, about 15% had abnormal LFTs. What was really concerning was the fact that in 8 studies, fecal shedding was measured, and there was evidence for fecal shedding of the SARS-CoV virus in 40% of the persons who were studied. So this is of some concern. We don't think of fecal spreading as a way of catching the COVID, but you may have read a recent New York Times article about the fact that flushing a toilet can create aerosols. And you may also remember some prior discussion we've had at this teleconference about the fact that when hospitals environments are studied for the COVID virus, the bathrooms are the place that have almost the highest concentration. So please keep this possibility in mind, that fecal shedding is seen in this big GI meta-analysis, and it's possible that someone could catch the virus that way, but it's not been proven. Next slide, please. So the treatment update, the swan song for hydroxychloroquine and chloroquine happened this week. It lost its FDA emergency use authorization. So in the Indian Health Service, we really should not be using hydroxychloroquine or chloroquine. The other really big news is the recovery study that was published in a press release by Oxford University. It's a single piece of paper, so we don't have the full publication yet. But they had 2,104 patients receive 6 milligrams of either oral or IV dexamethasone, and they compared their response to the response of 4,321 controls. So pretty massive study with really robust controls. And they found that dexamethasone reduced the risk of death by 35% in persons who were on a ventilator. So in order to see this effect on death, they had to treat 8 people. The number needed to treat was 8. Death was reduced by 20% in those who needed oxygen but were not ventilated. So in other words, it's more or less like intensive care unit, 35% improvement, med surg unit on oxygen but not on a ventilator, 20%. Number needed to treat was much higher at 25. So you can see the link to the Oxford University publication there. It's just a press release. The real study hasn't come out. This could be a game changer, but it's too early to say. We want to see their full publication, have it be peer reviewed and published, and then see if this enters into guidelines. I know there's a big temptation to jump on the bandwagon in the Indian Health Service, but we want to do things right. So I think I'd wait a few days until we can actually see the paper, and then go from there. Next slide, please. How about staff safety? Here's a paper, another one that shows that PPE really works. So this is a study of healthcare providers in Wuhan, China, who were deployed to a COVID unit. There are 420 of them total. About a quarter were doctors, 3/4 were nurses, and they all got what they called appropriate PPE, and they worked about 6 weeks from late January through early April. And they were a young population, about 36 years old, and about 68% were women. All of them had direct patient contact with COVID patients, and all of them were involved in one way or another with aerosolizing procedures. And at the end of the deployment, not a single person in that group had PCR evidence for SARS-CoV-2 infection or antibody development, either IgG or IgM. So kind of exciting that these patients, these workers did not catch COVID-2, and they were using good PPE. Next slide. I'd like to wrap it up with this really, I think, a very, very important paper that was published in the Annals of Internal Medicine on the 9th. And this is about resilience. This is a topic we've talked about in the past. And we had a speaker from the Brigham that spoke on this topic. And the title of this paper is "When the Dust Settles, Preventing a Mental Health Crisis in COVID-19 Clinicians." So you've heard about a famous sad story about a provider who committed suicide. And this is a discussion of what can be done to prevent this in the future. So in this article, which comes from Dana-Farber Cancer Institute in Boston, they present to us foundational set of principles to use as guidance for building internal support for the trauma caused by the pandemic, something that every one of us who've been doing COVID care now for the last 3 months know is a big deal, a big issue, especially now. So they recommend that providers try to look past the illness, and they say that we should, when we work with patients, we should try to reach out on a personal level to the family to remember who the person is, who the patient is outside of the illness, and think of them as a person. And so they give suggestions for things like finding out what the person's favorite song is while they're in the intensive care unit and playing that music on a recording for that patient so they can feel comfortable. And also try to learn a little bit about their family's relationship with the patient. So basically to humanize an otherwise dehumanizing event. And then they talk about fostering community within the hospital community. And they made the statement, healing requires community. So they recommend that we have weekly bereavement rounds where you can actually share grief about the death of our patients. We've thought about doing that here in Gallup and our palliative care group does this all the time to actually talk about those we've lost. And then they talk about promoting vulnerability. The popular press promotes healthcare workers as superheroes, and we all know that we're not. And they recommend that we have weekly, what they call reflection rounds, so a different kind of rounds to meet together, discuss how we're human, we make mistakes, we have limits in what we can do in the spite of a huge pandemic, and to basically recognize not just our patients' humanness, but our own humanness. So I thought that was a really helpful thing. And their fourth recommendation is we establish boundaries and limits, that we schedule time off for ourselves, and they really say this should be mandated by leaders. So leaders should recommend that people not work superhuman hours and work 7 days a week, be on call 24/7. This is a bad idea. So the recommendation is that we mandate scheduled time off. So next slide, please. I thought that was a really helpful paper worth looking up in the Annals of Internal Medicine on June 9th. These are the references we usually use from the CDC, American College of Physicians, University of Washington, the NIH, and Brigham and Women's COVID protocols. Next slide, please. Great, thanks. I always close with a slide from Nagaland, my family's homeland in Northeast India. So right now it's rice transplanting time. So it's a process of going through transition from the rice planted on the side of the field into this kind of widespread greenery that you see here. And our goal is to get the rice transplant into the water so that it grows really well. And we are going through a change in the Indian Health Service. So we've been working continuously for 3 months now doing COVID care, and we are going to be transitioning back to our opening our regular clinics. And I want to remind people to go slow, be patient with each other. I want to thank you all for the really hard work you've done over the last 3 months to care for COVID patients and work hard to maintain your own sanity. And I want you to kind of make that transition gently and do it really well. So really grateful to the team from the Brigham who will be speaking next. So I'll close there. Thank you.
Thank you so much, Dr. Iralu, and thank you for showing us that green and lush picture that those of us in the Southwest, it's something we haven't seen yet, but hopefully in the next couple of months as we transition into monsoon season. And clinically, we're all hoping, I think, to be transitioning into a phase of a reopening, probably not the reopening, but thanks for the segue there, Dr. Iralu, because we're joined by a leadership team with very deep experience in large level hospital and outpatient leadership. And we're very grateful to have them take time out of their busy schedule today to talk about some thoughts about transition into reopening. I'm going to first turn the call over to Bernard Jones, who's the Vice President of Public Policy at Brigham and Women's Hospital. And as I understand it, there's going to be a shared presentation moving forward. So please keep the questions coming. And thanks, Bernard, for joining us today.
Great. And please call me Bernie. And we'll introduce the full team here in just a moment. But I wanted to pause briefly on this opening slide because I wanted to contextualize the presentation that we're collectively going to be giving to you over the course of time during this time together. And it really is a focus on our transition out of the surge phase of the pandemic into the phased reopening that both we and our state of Massachusetts have used as the frame by which we're going to progress back into what we describe as our new normal. And we're pretty particular and purposeful with our language, and so we've seized upon this concept of recovery and reimagining, which is both our ability to come out of that crisis, but also use it as an opportunity, both through the forcing function of the persistence of COVID, but also the opportunity to do things differently coming out of something like this, to both recover and to reimagine. So let's see if I can do this. There we go. So our agenda as follows. We'll quickly introduce ourselves. We'll talk a little bit about what that phased reopening looks like from a variety of different perspectives. And then based on some of the direction we got for our presentation, really focus on the ambulatory and outpatient aspects of our reopening and hopefully its relevance to the work that you all here on the presentation are doing. So we'll now quickly introduce ourselves. Yara, did you want to kick things off for us?
Sure. Good afternoon, everyone. I'm Yara Davila. I'm one of the Senior Directors of Ambulatory Services for Brigham Health.
Great. And as was mentioned, I'm Bernie Jones. I'm the Vice President of Public Policy here and also Chief of Staff over our operations areas across Brigham Health.
Thanks, Bernie. I'm Cindy Peterson. I'm the VP of Regional Ambulatory Operations and Business Development for Brigham Health.
And I'm Tom Walsh. I'm the Vice President for Analytics, Planning, Strategy, and Improvement here at the Brigham.
Great. So we're going to start a little bit with describing the phased reopening, but before we do that, I think it's worth talking about what sort of our structure was during the pandemic and then how that relates to this recovery and reimagining structure. So like many of the institutions of which you are a part, we stood up an emergency operations group, which we called Incident Command, in the build-up and then through the surge of COVID. And this was a central management structure that allowed us to make quick, decisive action around response to the crisis. And that this move into recovery and reimagining doesn't completely replace that command structure, but orients it now towards planning and execution for what our opening would be. So I know that you all represent institutions from across the country. And so what I'm going to provide to you now is a lens into how we have informed our phased reopening, recognizing that region by region, state by state, there are going to be differences to this, but it may be helpful at least into understanding how we thought about reopening our enterprise. So you don't need to read all of this, but this is a graphical representation of how the Commonwealth of Massachusetts has directed its hospitals and clinics into thinking of reopening. And the phasing applies across all of our industries and business areas and aspects of our economy. So right now, we are in phase 2, which is this cautious designation. But really all of this commenced about a month ago when the governor lifted aspects of our emergency stay-at-home order and began giving license to the majority of businesses to start thinking about opening, but for hospitals like ours who had always been open, to think about what a broader opening might look like. And so not unlike the rest of the economy, we too were directed to open in phases, with each phase as listed here lasting approximately 3 weeks. But that reopening was really predicated on both statewide and institutional measures that would give the elected leadership of the state and hopefully the citizenry writ large comfort that in an instance where COVID were to spike again, that we would have an appropriate level of readiness to respond to that and in effect be better prepared than we were the first go around to quickly and ably respond to what a spike might represent here. And so for the Commonwealth of Massachusetts, this was a focus both on specifically adult ICU capacity, but also statewide hospital adult bed capacity. And so we here at the Brigham were able to use both our capacity levels, the capacity levels of our parent system, partners, now Mass General Brigham, and then there were also a variety of other measures related to PPE and others that would predicate our ability to move both into phase 1 and then into phase 2. And then this, I think, has some salience to the notion of what ultimately Tom and others will describe as our local phased reopening. So we imagined even before the state's guidance that we would follow a fairly similar phased opening where we initially focused on what we described as our urgent deferred cases, those cases that we put off during the heart of the crisis, where it was clinically appropriate to delay it for a certain period of time with the recognition that after that period of time, the necessity of that care would become more emergent. And so we initially prioritized in phase 1, as did the state, those cases. But as we move into phase 2 and ultimately to phase 3, we're going to be able to liberalize the kinds of cases we do and the kind of care that we provide across the hospital. And at the bottom of this slide, you're going to see a really important caveat, which is both felt for us and felt across the state, which is where possible, telemedicine and telehealth still needs to be the coin of the realm and really the priority area for how we provide care where it is possible. Because for reasons that Tom will touch on and Yara and Cindy will particularly go deeply into, these concepts of social distancing, safety, and space in our lived environment in some ways precludes a lot of the normal care that we would provide in a non-pandemic, non-COVID environment. And with that, I'll turn it over to Tom to talk through some of that tiering and some of that phasing.
Great. Thanks, Bernie. So what I'm showing here is just basically how we prioritized our patients. And what we really tried to do is link this to, the phased opening that the state had given us guidance in. So this is a really simple chart that we utilize to prioritize all of our clinical care components, whether it was surgical, procedural, or even ambulatory visits. And you can see I'll actually start from the bottom. I mean, tier 3 was basically, was high acuity patients. These patients needed to be treated right away. And either needed to be treated right away, or they were obstetric or psychiatric patients that we really couldn't defer their care. And so these are the types of patients that we actually saw throughout the entire COVID surge, and really have not changed and will continue to care for. So when we moved into, if you go to the next row up, we moved into phase 1. What we had planned to do is then expand the types of patients we see. And to Bernie's point is, at the start of this, we were allowed to, some of these patients we could defer for a few months, but we had deferred them long enough where we actually needed to start seeing them. So, this might be some, more moderate risk cancers that didn't need to be cared for right away. But as we moved into phase 1, this is the first set of population that we actually started to prioritize over sort of those crisis patients. We're now in phase 2 and moving into phase 3. And so we've expanded our capacity to care for, a much broader set of patients. And so these don't necessarily have to have life-threatening conditions. They could just be, patients who are more elective in nature, and have conditions that ideally during COVID surge we didn't want to bring them in, but as a result of our progress in the state level, we felt it was appropriate. And so this is kind of the tiering system that we use to kind of prioritize during each phase which patients we would see and which patients we would hold off on providing care in an in-person manner. Next slide. So I'm first going to talk a little bit about our ambulatory approach, and Cindy and Yara will get into much more the details around how we set up our practices around ambulatory. But what I would say is this is the area we probably closed down the most during sort of our COVID surge. And so, the numbers in the table are a little bit small, but you can see, prior to the start of the surge in February, we were seeing, pretty high numbers of in-person visits and very few virtual visits. And as we moved along through March and April, you see a changing in the number of virtual visits, where basically about 80% of the patients we actually saw were virtual. Now, we weren't seeing the same volume of patients, but similar to many other people, we had shifted to a primarily virtually care platform because we were really only focused on seeing those patients in person that kind of met our tier 3 criteria. As we've moved into phase 1, see that next column, we're starting to see ramping up of our actual ambulatory clinics. So what we're seeing is, we have slowly ramped up into about 40% of our normal ambulatory clinic volume. And you're starting to reduce the amount of virtual visits that we have seen from what we were seeing before. What you will see, and the graph below starts to illustrate this better, is the green line is really over time and over each of the phases is the in-person visits. And so we had a pretty low number during COVID, around 4,000. And then over time, over about 3 months, our plan is to actually quadruple that and get up over 16,000. At the same time, our virtual visits will go down, but it will actually maintain, will go down, but it will only go down slightly. And so what we're planning to do is, before, where we had a lot of in-person visits and they basically made up all of our ambulatory volume, we're shifting to a platform where, we are still going to see that same volume by week 12, but that volume will be more 2/3, 1/3, with the third being virtual visits. Next slide, Bernie. And so the next two slides just give you a sense of what our approach has been from a procedural as well as an OR perspective. I'm not going to go through this entire slide, but I'll just focus on the first column, which is endoscopy. And during the crisis, we really normally we have 18 rooms, 18 endoscopy suites, and those were closed. And week by week, we have slowly increased the number of endoscopy rooms. And similar to ambulatory, what we're trying to do is open sort of our operations little by little, because we want to make sure that we work through all the kinks, make sure whatever we do actually is safe for both our employees and patients. So, as expected, instead of going big bang, we're really doing it on a very incremental level. And so you can see for endoscopy, we almost get back up to full capacity over a couple-month period. And, similar, you see that for some of the other procedural areas. Next slide, Bernie. And then the operating room, it's a very similar chart. I'm not going to go through it, but once again, using that phased approach to get us back to what we were before and trying to take things slowly, so we make sure that whatever we do, we're able to support both our patient volume and our employee volume in a safe manner. So now I'm going to turn it over to Cindy and Yara, and they're going to talk about the work we've done in ambulatory in order to stand that up and provide a safe environment for both of our patients and our employees.
Okay, thanks, Tom. I'm Cindy, as I mentioned before, and Yara, you will jump in if you want to elaborate on anything. So, Bernie, do you mind going to the next slide? So just to level set everybody, we did have several of our ambulatory practices remain open. Mostly our large multi-specialty and primary care practices remain open through the pandemic, but our volume was off by 90%. It was very slow. And then as the slide shows, starting really in early May, we started planning. And as of May 18th, we were able to take our first steps in terms of reopening across the ambulatory world for the Brigham. And what we really thought about first was, let's take this in sort of short-term and then midterm steps. So for 0 to 60 days, we really needed to work with the resources that we had at our fingertips around minimizing the densification of space, thinking about the proximity of patients and staff and visitors to one another around physical distancing, and really looking at our cleaning protocols, making sure that we were being very disciplined about that. And I'll talk a little bit further in the deck around plexiglass barriers, but suffice it to say that at the beginning of our reopening, we didn't have plexiglass to play with. So we had to work with what we had. Bernie, next slide. So in terms of the patient waiting areas, we challenged our practices to really think about, what do you have that you can work with? Take a look at your patient parking lot, for instance. Can you set aside space for a cell phone waiting area for our patients, especially if we start to see patients queuing? If you think about some of the practices with walk-in services like X-ray, like urgent care, like phlebotomy, you can have a lot of people showing up at the same time, and you have to be prepared to handle that, obviously. And then, thinking through overflow waiting areas. So what used to be used as conference rooms, we don't have as much of a need for conference rooms right now with people working from home and these sorts of Zoom calls and the like. So we wanted to repurpose conference rooms as overflow patient waiting areas. We've done that. And then being able to, if we are concerned about the waiting room volume, being able to make a decision on the fly to room patients immediately upon arrival. Workstations on wheels have been very helpful with that because you can pull it right into an exam room and check a patient in that way.
Can I add one thing there before we move on? I think very similar to your health system, not all of our ambulatory practices and buildings look alike. So many of them have different physical barriers that may prevent certain options. So as we created these checklists and our guides, we wanted to create a lot of flexibility within them, because a place like Foxborough, which is one of our major offsites, is a lot different than a smaller practice that we have in the South Shore of Massachusetts, who literally can only fit 2 to 3 people. So we really wanted to create flexibility and the ability to be dynamic with these options, because we understood that as a barrier.
Thanks, Yara. Bernie, next slide, please. So we had to get creative. You'll see blue paint tape. Nobody likes blue paint tape on the floor, but in the absence of stickers for the floors, and I'll show you some pictures as we've evolved, we've been able to provide the practices with tools that actually are a little clearer in terms of direction, as opposed to paint tape with a sign stuck on the floor. But you have to do what you have to do to make sure we're keeping our patients and staff physically distant. Then you'll see the lower photo. That is a repurposed table from the waiting room that allows us to create that physical distance with a sign on top of it. So again, getting the practices to be creative in their approach, working with what you have, and creating that visual cue for physical distancing. Next slide, Bernie. This is just a few more examples of the many creative approaches that the practices had to take, whether it's furniture as a physical barrier, or signage with ribbons, or caution tape, which I'm not a fan of, but you work with what you have. This is what it looked like in the first, I would say, 30 days. Next slide, Bernie. So as we moved along, this, we've kind of evolved now. We are getting plexiglass. We're ordering more plexiglass. If you look at the upper right photo, you'll see a sticker on the floor that indicates where a patient should stand. And we've come up with a system in terms of the practices. If they need a plexiglass solution for their check-in desk, there are, depending on where your location is, there are different resources for you to tap. But what we really had to do, and Yara and her team were instrumental in this, is visit all of the off-campus practices, assess their waiting area, assess their check-in area, and assess their workstation area, and then make some recommendations and quantify it in a big old spreadsheet to make sure that we were capturing the need, and we could then make the order around plexiglass. Yara, anything you want to add on that? Oh, you're muted.
All right, nothing to add, thank you.
Okay. Next slide, Bernie. This just gives you another picture. This is as we evolved a little bit more. So instead of the blue paint tape, we've got the stickers that say, please stand here. And then the red stickers on the chair basically say, please don't sit here. So it's clear that the chair is not there for sitting. We actually ended up turning it around and putting the sticker on the seat of the chair so it was clearer. But this is at the check-in area. So we want patients to be able to step up, but step within the right level of distance from the check-in staff. Next slide. These are just further pictures of how you can create physical distance, whether it's ribboning off chairs. We actually ran into some challenges. If you look at the upper left photo, all of those chairs are ganged. So they're all attached to each other. So when in a normal circumstance, it's great because they look great, they stay in line. But when you have a situation like we had with the pandemic, it's a problem. So I'm not a fan of ganged chairs moving forward. But really just making sure we're assessing all the chairs, and if we had cloth chairs with cloth arms, we couldn't use those anymore. They have to be cleanable. The surface needs to be cleanable. So a lot of educating of our teams around that. Next slide. There's the blue paint tape again. We do what we need to do. So when you have a narrow corridor and you're concerned about patients passing each other in a two-way fashion, and if you have the flow available, create it as a one-way corridor. So we actually are creating some floor stickers that look nicer than this paint tape, but for the purposes of creating a safe environment for our patients, when this particular clinic reopened, we put the paint tape down and it's working very well. Next slide. So the staff lounges are areas where you can imagine we have to be particularly vigilant and mindful, because this is where people take their masks off to eat. So we really have worked to try to figure out how many tables and chairs can we actually have safely in the staff lounge. We've had to reduce the occupancy level of the staff lounge drastically. And then in the circulation area, we have to make sure people understand when you're seated and eating, you have your mask off. When you're circulating, you have your mask on. But this is definitely an area that we've continued to monitor. We use a lot of signage in the staff lounges, and so far so good. Things like staggering staff break times is really important. And then if you can create some overflow spaces, whether they be conference rooms or other meeting areas, so that staff can have other places to eat. We've also tried to invest in some outdoor furniture so that staff, you know, it's New England, it's summer, it's a nice time most of the time to eat outside. So wherever we can create physical distance safely for the staff, that's what we're going to do. Next slide. In terms of housekeeping, this also has been something that we've evolved with the infection control into some enhanced cleaning protocols. I'm sorry I didn't include them here, but certainly making sure that the cleaning staff is hitting all of the areas from a patient care perspective that could need cleaning. It's a higher frequency now. And there's a nice spreadsheet that's been circulated. And it's based on, that spreadsheet's based on 7 a.m. to 8 p.m. clinic, 5 days a week. And if you have a clinic that's running shorter hours, there's an algorithm that our team's created just to make sure that we're staying right on top of the cleaning frequency. Things like touchless Purell dispensers are really helpful. And then we also are making sure that our clinical support staff knows the cleaning protocol, because they're involved in it as well. They're turning the exam rooms, so they're doing the cleaning in between patients, and they're monitoring the floor if there's cleaning that has to happen on the floor, which is not between every patient, but as needed. Next slide.
And Cindy, if I might, it might be helpful to contextualize that commitment to cleaning in our sort of broader Brigham Health and Mass General Brigham-wide push in this area, which we call our Safe Care Commitment. So this is a series of well-articulated, publicized means by which we seek to reassure our patients, their families, and our employees that the Brigham has been, but is especially now, a safe, clean environment for them to come to. Because as you may experience yourselves, and we certainly experienced, opening the doors wasn't sufficient to return to normal business. It really was assuaging many of the concerns that our patients and their families had about returning to this environment, whether it was masking, whether it was the cleanliness of the environment, whether it was their ability to bring visitors and guests to the environment. So, you know, it's just a quick page in the summary, but this notion of keeping our environment clear has dominated our thinking and approach over the last few months, because we view it as really one of the linchpins to a return to successful normal operations.
Yeah, thank you, Bernie. That's a key component of what is important for us to be able to message to our patients and our staff. So physical distancing in elevators, I spoke about that a little bit earlier. I'm mindful of the time, so we could, the one thing I would note is floor stickers in the elevator cabs on the floor is very helpful to indicate where patients and staff can stand. Next slide. And then in terms of signage, it's really helpful to include in this slide deck, which we have, some signage that we've been able to then circulate to the teams, and they can just print it out and put it out wherever they need to. So we've included some of the signage that you may want to adapt. So we can just run through them, and also reminding our patients for patient-facing signage, that Patient Gateway is something that we would love patients to, if they haven't, take full advantage of. Yara, you may want to speak to Patient Gateway.
Sure. So in addition to all of the infrastructure work that was led by Cindy, we also looked at technology and leverage technology in a few different ways, mostly ways in which we can engage our patients through our patient portal in advance of their visits. So a few months ago, prior to COVID, we across Brigham Health and MGB had actually launched electronic or e-check-in, where essentially patients could pre-check-in for their visits. And so in a post-COVID world, what we did is we created questionnaires and reminders for patients, sort of electronic triggers to say, if you're feeling symptomatic or have any of these symptoms, please call us before you come in, or actually having screening questions launch or fire in advance of their visits, and sort of showing up in Epic, which is our health record, to let our practices know which patients were feeling asymptomatic prior to their visit versus those patients that we should probably call and pre-screen in advance of the visit. In addition to that, at scheduling, we leverage a functionality within Epic called Decision Tree, again, across the MGB system, that essentially pre-screens patients prior to scheduling, and it enables the clinicians and the schedulers to work together to determine whether a patient should be seen in person, virtually, or have a deferred visit, meaning they might need to be seen in person, but it is clinically appropriate for that to happen maybe 3 or 5 days after their symptoms have resolved. And that is a partnership that happens at scheduling between our clinicians and it could be a nurse, it could be an advanced practice provider, or it's at the actual doctor, depending on the practice and the size of the practice that engage in them. We're also, this week, we're piloting virtual waiting rooms, and so we're using one-way texting technology to sort of help patients stay in their cars prior to coming on site. I think that's another thing. And then education and reinforcing the safety protocols for our staff and our providers has been a big piece of this. So we are holding a lot of town halls. So on a monthly basis, our associate chief nurse of ambulatory and associate medical CMO hold these town hall meetings where they sort of give updates on things and basically take a lot of Q&A from our providers across the enterprise, the Brigham Health enterprise, and help answer a lot of questions. And that's really helped boost confidence in the process and in our level of preparedness. So those were some strategies that I think worked in addition to what Cindy has outlined.
Well, Sean, I think that's our presentation. We're happy to approach the Q&A however you'd like. I've got the Q&A dialog box here. We're happy to start there, or if there's another approach that you'd like us to take, just let us know.
Thanks so much. Yeah, we definitely want to get to these questions in the Q&A. I just wanted to highlight that point that Yara made. Well, first of all, let me thank you all for just a terrific presentation. I think the our suspicion that the MGB enterprise and the range of different sites that you all oversee really lends itself well to sharing your experience with our team, because we have a wide range of sites represented on this call from across the nation. So thanks again. With regard to the communication piece, I just wanted to highlight that point, Yara. I think that's, within our sites, we see that as a continued challenge. And I think I'll speak for myself, having been involved in leadership at Fort Defiance, underestimate the importance of continuous communication to our teams. So thank you for bringing that up. Bernie, you can see the Q&A, and I wonder if you might be able to help direct the questions to the best folks on the panel.
Sure. So the first question is, have you experienced any pushback from staff regarding wearing masks? And what are the policies for those who do not want to wear a mask? So I'll start answering this in a couple ways, then turn it over to my colleagues for additional thoughts. So interestingly, we were, I think, among the first academic medical centers in the country to institute universal masking both for our employees and for our patients. And so we saw a really ready early adoption of surgical and procedural masks across our enterprise, and really as an important statement about our commitment to the safety of others, whether our patients or our fellow employees. You know, I think the pushback has largely manifested itself, at least here at the main site, on those who want to come in with a cloth or home mask rather than using the surgical and procedural mask that we hand to everybody who enters the facility. And the way that we've worked around that has been that irrespective of your sort of immediate mask, all masks worn in the hospital need to be covered then by the surgical or procedural mask that's distributed at the point of entry. So, you know, especially along the way, some folks would bring, say, an N95 that they had from home or a cloth mask, but our expectation was that the hospital provided masks would be on the outside, recognizing we don't particularly want to get in the mask policing business at the hospital, but we also want people to be safe. But Cindy, Yara, from your perspective in the ambulatory enterprise, is there any difference there?
I haven't found any pushback from staff with regard to wearing a mask. To Bernie's point, we've been doing it for quite a while, and I think the communication from the Brigham on a regular basis has been so helpful to really understand the power of the mask, and that the mask is helping the community, really. I think it's been very well documented and well communicated.
Yes, I agree. Don't have a comment on masking, but did want to say that in addition to the town halls, we also created a daily, initially once upon opening, we were sending out a daily briefing to all of our ambulatory sites with just updates and clarifications. And as things got a little bit steady, we now send it twice a week, and that has been really helpful to our ambulatory community as well in terms of feeling up to date and in the know. So that's another communication thing we did.
Great. And I'll just quickly jump ahead to a slightly later question, which relates to the PPE recommendations for reopening, and will providers with direct patient care need to wear full PPE as though everyone is presumed positive? This includes gowns, gloves, masks, and eye protection. I'm about as far from a clinician as you're going to find, particularly with this esteemed group. But what I'll say is that we have, as a hospital, gone through the various evolutions of both the ability to access PPE and then balancing the CDC and DPH requirements for PPE for the various procedures and various patient interactions across the hospital. You know, Yara and Cindy are probably better positioned to talk about this within the ambulatory enterprise. But what I would say is that the PPE challenges persist, as well as the clear distinctions about those care provisions that require full PPE versus those that simply require a procedural or surgical mask. So, you know, there is not a short answer to this question, but Cindy, Yara, did you have any ambulatory specific perspectives you wanted to provide here?
I think, Yara, you've lived it much more than I have in terms of the PPE distribution. I will just say that some of the infographics that Yara and her team have created in conjunction with infection control have been extremely helpful. We've plastered them all over the place in our practices, and it's a reminder as to why you would need what level of PPE and when you wouldn't need what level of PPE. So Yara, do you want to jump in?
So in ambulatory, we partnered very closely with our infection control colleagues and our safety officers, and essentially created an infographic because of the many roles in the ambulatory space. Our approach was to not do it by role, but to do it by scenario. So what we did is we created an infographic, and essentially it shows for different types of procedures what the appropriate PPE is. So if essentially it is a regular office visit with a person who is not suspected or has any form of upper respiratory infection, then the guidance there is to use your regular hospital issued mask. If you're doing an aerosolizing procedure or are basically taking care of a patient for more than 10 minutes who is unable to wear a mask, we found as we've opened up that there are certain patients who just clinically, due to some of their illnesses, can't wear masks, and then we recommend full PPE in that scenario. And obviously if you're doing an aerosolizing procedure as well. So we have these scenarios that over time, as different scenarios have come up in the ambulatory setting, we have worked with infection control colleagues to tweak them. and update the infographic to really help people understand when PPE is used so that we're being good stewards of our fragile supply chains, but also keeping our staff and patients safe.
And I know we're running short on time, but I did want to at least start an answer to one of the other outstanding questions, which relates to how to handle patient flow into the facility. Specifically, do we allow any and all patients to just walk into the hospital, or those only with appointments? And then a follow-on question about more specifically the high numbers of usual non-ER walk-in patients. So yes, we do restrict flow, particularly here at the main campus. So there are entries that are specifically designated for staff, and then those that are specifically designated for patients. All individuals entering the Brigham need to attest symptomatically to identify whether they have the sort of normal symptoms associated with COVID-19 or not. So that is a point of restriction for those who would enter the hospital. And until very recently, the Commonwealth had fairly restrictive guidelines around visitors and their ability to enter the hospital. And so I think we saw quite a low flow of individuals into the hospital who are not employees and not patients, effectively none, absent some exceptions. That policy has been liberalized at the state level. We now are allowing one visitor at a time here on our main site. I know the ambulatory group is working to adapt, given the sort of close quarters that many of their practices have, to also allowing visitors. But that's been the main factor. And then just quickly before Yara and Cindy answer on the ambulatory visitor side, the ER, interestingly, has seen a lower volume, and perhaps not interestingly, not surprisingly, a lower volume of walk-ins, but they too face the same limitations and strictures around access, entry, attestation, et cetera. But Yara, Cindy, did you want to say anything about in the ambulatory setting?
Yeah, I think the only thing I would add, some of our practices really assessed how many entrances, and I know the main campus did too, how many entrances we actually had, what could we make an all-employee entrance, what could we then make all-patient entrance. So that was helpful to control the flow and not have too much congestion in one space. And then trying to think, there was another point I wanted to make. Yara, I don't know if you have anything you wanted to add.
Yeah, the one thing I'll add is, when visitors enter, they are met by somebody and they do have to answer a number of questions in order to gain access. And all visitors are also given a surgical mask, and they must, they are required to wear the surgical mask in almost all cases.
Yep. Thank you, Tom. You spoke long enough that I remembered what I forgot. So the other piece was when we first really started reopening, the patients would make their way to the practices and they would be asked the questions that Tom just explained. Then we really said, let's stop them in the main lobby. Let's have that interaction so that the practices, the front desk in particular, folks at the front desk, were able to know that anybody who made it to their practice had been screened already. And that, especially in the first few months, that was really helpful to kind of calm some nerves. As we get busier, it's harder and harder for us to manage all of that in the main lobby, but we're figuring it out.
And Sean, I know we're right at time. There is one question about where one can secure stickers for floors and chairs. I don't know if you want to quickly answer that or type the answer in the Q&A. I'll defer to you.
I don't know it off the top of my head, but Cindy and I could look it up. I did provide my email in the chat. So if you're interested in that, if you just email me, I can respond with that piece of information. I just don't know it off the top of my head. Unless you do, Cindy.
It's Cadwell, but I think let's formalize it. Yeah. Okay, good.
Thank you. And I think there's just one last piece in the final, as we're T-minus 1 minute here, or over 1 minute. As Cindy had mentioned, the survey that you did of each of the clinical areas, could you just quickly talk about the team composition as you're going through your clinical units, trying to make decisions around safety and infection control?
Sure. The survey that we did was primarily infrastructure. So we were focused on the types of chairs in the waiting room. Do they have cloth arms? That's a problem if that's the case. The size of the waiting room, the throughput needed in the clinic. So all of those things became factors for us to figure out what they needed for plexiglass barriers. Your other question, Sean, though, you were thinking more around infection control, and I know there's been so much work done. Yara, I don't know if you want to add anything there.
Yeah, so again, we're not the infection control experts. We partnered with our hospital epidemiologist. They assigned somebody to ambulatory who worked in conjunction with our clinical leaders to really help us form our clinical guidelines and ambulatorize them. Obviously, the inpatient setting and EDs and ORs are very different. And so that's really what we use. The organization created an infection control playbook, which we then took and use to help guide our operations.
So it sounds like a combination of engineering, infection control, clinical leadership, making their way through each of those areas. Well, thank you all so much. I want to be respectful of your time that you've already given us over an hour. We really appreciate your participation in our clinical readiness session today. So to Yara Davila, Bernie Jones, Cindy Peterson, Tom Walsh, thank you again. And Ellen Bell, of course, who's behind the scenes helping coordinate this collaboration between Brigham and Women's Hospital and IHS. A thank you to IHS leadership for providing support for these sessions each week and allowing us to have the time for these very important meetings, especially in this time as we look to reopening, which is going to present a whole range of new challenges for us. To the Project ECHO team in the background, keeping us running safely and smoothly through these sessions every week. Thank you very much. To all the attendees, please remember there's a link for CME in the chat feature. Yara shared her contact information. If you have any more questions, you can cut and paste that quickly before we end. And there's links to the slides in your invitation that was emailed out prior to the session, as well as in the chat feature. Thank you everyone for participating. Thanks again from Brigham and Women's. You all have been terrific partners throughout this entire pandemic. Several installments of your expertise have been very helpful for us. So thank you all. We'll look forward to seeing you all hopefully next week out there in the world of IHS and 638. Until then, everyone stay safe and be well. Thank you all.